Hello, good morning, good afternoon, good evening. Welcome to our panel entitled Dual Pandemics, COVID-19, Racism, and Decolonizing Global Health. I'm Renzo Ginto. I'm speaking from the Philippines. I am currently the inaugural director of the new Global Health Program of the St. Luke's College of Medicine, again here in the Philippines. And I am your moderator for today's exciting panel. COVID-19, it's the biggest challenge that we have right now in global health. And COVID-19 has also showed to us some of the chronic challenges that we have in global health governance, in policy making, in financing, in the way we conduct our research, in education, etc. And in the past several months and years, there's been a growing conversation around this idea of decolonizing global health. Several papers have been written already, a lot of webinars, conferences organized in various universities around the world. But what does decolonizing global health really mean in this era of COVID-19? And mentioned in the title as well is the other challenge of racism. And especially over the past several months, we've seen in the United States, these protests around the Black Lives Matter movement, calling for really tackling the root causes of structural racism. And we know that racism also contributes greatly to the exacerbation of health inequalities, not just in the States, but in the world entire. So these are just some of the big questions, the big challenges that we would hope to tackle and address in the next several minutes. And I am grateful that I have with me some of the thought leaders in this evolving conversation around decolonizing global health. Our first speaker is Anu Kumar. She's the president and CEO of IPAS, an international reproductive health and rights organization that focuses on access to contraception and abortion. IPAS is also part of the Triangle. Dr. Kumar is an internationally recognized advocate for women's rights. And as I've said, a thought leader in global health, particularly in this emerging conversation around decolonizing global health. Prior to joining IPAS, Dr. Kumar worked at the World Health Organization's Reproductive Health Research Division in Geneva and spent 7 years at the MacArthur Foundation in their Population and Reproductive Health program. Joining Anu is Laura Mukumba. She's a native of Dar es Salaam, Tanzania, by way of Atlanta, Georgia. She received her Bachelor of Science in Biology and Master of Science in Global Health degrees from Duke University, also part of the Triangle. She co-founded the Duke Decolonizing Global Health Working Group in 2018 to create a space for students, faculty, and researchers to critically reflect on the legacies of colonialism embedded in the field of global health. She has spent the last decade working in international and domestic HIV/AIDS research, ranging from investigational drug clinical trials, HIV prevention studies, and behavioral interventions. She's currently working in FHI 360. And finally, all the way from South Africa, we have Shannaz Munshi, a health policy and systems researcher and activist with a particularly interest in feminist, the colonial scholarship and praxis. She is also an occupational therapist with 10 years of experience serving vulnerable and marginalized communities in South Africa and the UK. Currently, Shannaz is affiliated with the School of Public Health, Wits University. She also serves on the steering committee of the People's Health Movement, a global network of grassroots health activists, civil society organizations, and academics committed to advocating for affordable, accessible, and equitable health for all. She's also the co-founder of African Health Futures. Anu, Laura, Shannaz, welcome to the panel. It's amazing that we're all in this transcontinental conversation, at least 3 different time zones, I believe. So let me begin. And I gave a quick intro a while ago, but I want you to help me really dig deeper into this idea of, the dual pandemics of COVID-19 and racism. Maybe you can reflect a bit about not just COVID-19, which we know it's the pandemic that we're trying to tackle now, but also racism, and why why the it's important to really recognize the inextricable linkage between the two. Maybe I'll start with Anu.
Thank you, Renzo, and thank you to the Triangle Global Health Consortium for inviting me and for having this conversation. I think it's not just timely, but extremely important and urgent, actually. It's urgent because, as you have rightly pointed out, the racism is a huge variable and factor in the deaths and disabilities that we are seeing due to COVID-19. But I want to point out that this is not new. It is being made visible in very stark and real ways with this pandemic. And I think, frankly, that it's become visible because not just Black and Brown people are dying. You know, everyone is afflicted by this pandemic. And it is true, of course, that the rates of mortality and morbidity are much higher among Black and Brown people. But the pandemic doesn't actually see race. It sees the comorbidities, it sees the health inequalities, it sees poverty, it sees those underlying factors, and then really takes advantage of them. But, frankly, we have seen disproportionate impact of any number of health problems on Black and Brown communities for decades, if not centuries. So definitely not a new issue. Just frankly, in my own topic at IPAS, as you mentioned, we work on safe abortion and contraception. The reason we focus on that topic is because unsafe abortion is one of the 5 leading causes of maternal mortality. Well, who dies in childbirth and pregnancy? Black and Brown women die in pregnancy and childbirth. Even in the United States, it is, African American women have 4 times the maternal mortality as white women do. So, I think that the pandemic has really made it clear, made it obvious, made it undeniable. But in the global health community, I think we have known for a very long time that racism is really at the root of many of the ill health that we see around the world. And certainly we see it at IPAS in terms of our programming and our work. It is African women, it is women in South Asia, it is women, poor women everywhere, whether they're in Kenya or whether they're in North Carolina, who most suffer and die from unsafe abortion and lack of access to contraception.
Thank you, Anu. How about you, Laura? How do you see the confluence of these 2 pandemics, especially from where you stand or where you sit? You're sitting in front of a laptop. I think that's the part of the Zoominization of conferences. So how are you seeing this dual pandemics of COVID-19 and racism, interact? Especially now.
Thank you, Renzo. And I just want to echo what Anu just mentioned with racism being the root of health inequities that we're seeing. And I think that is one thing when I saw the title and I started reflecting on even calling racism a pandemic. Because, and I'm going off of, as a recent student, the definition that I was taught of what a pandemic is, it's a new disease that is afflicting multiple countries. And I think even calling it that sometimes washes over the fact that racism has always been here. And racism underpins, and racism specifically white supremacy, underpins a lot of the fields that we're working in and a lot of the systems that we're working in. So it is not surprising, as Anu mentioned, that we're going to see disproportionate rates and severe illnesses and severe health outcomes in Black and Brown communities. It is not surprising, specifically to speak in the context of the US, where we're going to see indigenous populations, if we're thinking of the Navajo Nation, where if they were recognized as a state, they would actually have the highest rates of COVID and COVID deaths. And so it's not surprising because this is underpinning both the healthcare field, it's underpinning global health, which we all work in different scopes. It underpins politics and policies. And so it is not surprising that we're going to see that they're interacting together. And really, racism is going to fuel these health outcomes. While like in COVID-19, you can be infected, anyone can be infected. I think it's really because of the social political position that you occupy, it will determine, your race or your ethnicity and your gender, and honestly, your sexuality and all of these other social political positions that will determine whether or not you survive and whether or not you live. And also just to highlight, even for us to have this conversation transcontinental over Zoom, I think it's one way that I want to highlight too, kind of these inequities that COVID-19 has highlighted and really put to the forefront is it is the most privileged people who get to be able to continue having these conversations and to stay connected. And thinking of even with education and who is going to be able to, after this pandemic, we're past this stage of this pandemic, who is going to fallen behind, and who is going to be able to continue, and who's been able, for the most part with adaptations, been able to continue living and connecting and continuing to having these conversations. And that is, to just point out that there is a privilege for us to be able to even have this, transcontinental conversation. So.
Thank you, Laura, and I really appreciate that you already raised, this concern about our collective privilege, and I think later on we have to interrogate that privilege, especially the privilege that many of us in the field of global health, which is a privileged field in itself, does have, and how can we turn privilege into the transformational, change that we want to see, and some may call it decolonize global health. But what is it really? And we'll get there shortly. And I really like also that you reflected on the term pandemic. In fact, I think we need to describe now racism more and more as a pandemic. We always describe it as a social issue, but it is a pandemic. And I also got remembered another term, which I think came from the field of anthropology, syndemic. And syndemic is when multiple epidemics happen at the same time, and there's an interplay between these epidemics. And so maybe COVID and racism, they're not just a dual pandemic, they're actually a syndemic, along with the other health conditions. Because of the COVIDization that we are seeing now, we tend to forget that racism also kills more people of color in terms of heart disease and diabetes and other infectious diseases. And so it's important to remember that. I will now go to Shannaz. And Shannaz, you're speaking from South Africa, and South Africa and Africa in general has also been grappling with all these difficult conversations around race and colonialism. Are you seeing this dual pandemics as well in that part of the world? And perhaps what can America learn from the experience in Africa and also in other places outside of the US? Shannaz?
Hi, Renzo. Thank you so much. I just wanted for inviting me to this panel where we can really exchange and bring such interesting people from all over the globe into conversation today. I think, when coming from South Africa, it's important always for me to understand our history from a, historicizing where we sit. And racism is really, even myself, being from Indian origin, coming into a space from one English colony to another kind of colonial home. My life and my entire lived experience is shaped by this issue of racism, colonialism, apartheid, and other versions of post coloniality or neo-colonialism, whatever you wanna call it. And for me, it's always centered around the question of power and who has power and where does the power sit and how does the power replicate and manifest itself in the structures and systems of our spaces and institutions. And in South Africa, we see a case where even though we got political freedom, we are in a post-colonial space, the systems and the structures remain the same. They remain inevitably in favor of those who had power during the colonial time, which inevitably is those who are white. And so we need to understand that the systems and structures, and even South Africa's most beautiful constitution, ends up defending those that have privilege, and they fail those that are poor and sitting in the margins. Now you come along the way, and we see working on the field, working in the ground, working in spaces where in structurally violent communities, in clinics that are underserved, it is clear that the inequalities in South Africa are widening. They're not bridging, they're widening, So the question is why? Does it matter about who is the color of the skin of the people in power? Or do we need to look to the structures and systems that continue to perpetuate these same systems of oppression? In the Africa Health convening, Professor Elawani Ramagundo, she called racism genocidal. That was something quite difficult for me to digest, but it's quite clear that that is the case. And how it manifests is not always in the form of police brutality behind the gun, but it is manifested in the lack of services and the continued perpetuation of Black and brown people who face the wrong end of the stick. Now, when COVID-19 came, South Africa went into one of the strictest lockdowns in the entire world. But this lockdown served people who are sitting like me in your middle class homes, who can close the doors, can sit behind your private security bars and literally remain free of the disease. Yet people in the communities, particularly people like the late Collins Kosa, who was sitting in his own home when he died from police brutality, or the late Elma Robin Monsumi, a sex worker who was in Cape Town, who was found dead in a police cell as a result of the lockdown. These unnecessary deaths remind us that Black and brown people, their bodies are sites of violence. And especially if you're woman, especially if you're queer, especially if you're Black, and especially if you are historically disadvantaged, especially if you're a migrant in the South African context. Now, racism in South Africa plays out in many different ways, and racism has different faces, and some of these faces are in a xenophobic form. So it's not so clear cut around how the racial dynamics occur. But what's more important is to maintain that the colonial powers intentionally create systems and structures for divide and rule. So they intentionally wanted different people of color to be occupied with this process of finding power dynamics within, which continues today to be another pandemic or syndemic or whatever it is, that keeps us in a state of occupation and dehumanization and othering and alienation. And it doesn't allow us to ask the difficult questions. How do we go back to think what happened before the colonizers came? Because there clearly was a pre-colonial time. There clearly was a time where history can show us that there were other systems of knowledge, other systems of power, other systems and ways of being and doing in the world, other ways of gendering oneself in the world they can maybe give us a clue that this isn't really a power that has to remain, that it is a choice we're currently making. We're currently choosing to be this way. We can choose as easily to emancipate ourselves, liberate ourselves, and move away from the systems and structures of power that comes from a point of evil, to move to a place where through our ideas and our praxis and our language towards a space of love, of of radical compassion, of tolerance, and of reciprocity. And I suppose for me, that's a more interesting conversation to really have in these kinds of spaces. And I'll stop there.
Thank you so much, Shannaz, for your rich intervention. There's so many to pick up from what you just said, and indeed, you know, racism has many different faces. You mentioned about the brutality, but you also somehow touched on, you know, how healthcare services are being provided to different kinds of different groups of people. Maybe later on we'll have a discussion about what is the implication of really acknowledging racism in the design of health services, which a lot of the organizations in the triangle, you know, do work on, especially in their global health projects. But you also reminded us about the importance of going back to history, and you know, you reflected on you know, not just the history of South Africa, your personal history as well, from, you know, moving from one colony to another. You know, I started thinking about my own colonial history as well. By the way, my country is named after a colonizer, Philip II of Spain. That's why we call the Philippines. And America is also named after a colonizer, Amerigo Vespucci. And so, you know, there are a lot of colonial remnants that are still around us. But of course, these are just the cosmetic. You are asking us, Shannaz, to really dig deeper into the structures that perpetuate the systems of oppression. And you want to, you know, go into that as well. And now let's go to this idea of decolonizing global health, because it seems to me, and I've been an active participant in this conversation, it seems to be that, you know, in order to address those systems of oppression, we need to decolonize, which is a term that has so many different definitions. And I will be asking each of you how you actually, you know, define and interpret decolonizing, and specifically decolonizing global health from where you sit. But another idea that I'm getting from your remarks is decolonizing global health is perhaps fighting racism that afflicts global health? Or is that too simplistic a definition or a conceptualization? So let's reflect on this decolonizing global health concept, and are we getting it right? Who wants to start the ball rolling?
I'm happy to start a
Sure,
little
Anu.
bit because I think both Laura and Shannaz, you know, made you know, referenced not just race but gender and sexuality and you know, I think Shannaz said people on the margins. So I think it is much bigger than race, actually. And I think it is a mistake that we make as a community when we talk about decolonization to only focus on race. Not that it's simple, but it is one of many. Because I think we have to kind of step back and think about what the process of colonization meant. You know, it was around white supremacy, as Laura rightly said. It was about power, as Shannaz also mentioned, but it was also fundamentally about domination. Domination of people who are not white, people who are not heterosexual, people who do not conform into a very strict definition. And that definition was for a purpose. The purpose was economic exploitation. So I think we have to be really clear that the decolonization conversation, which is happening in global health and needs to some extent happen much broadly in the overall development sector, is much bigger than we think. And because of that, I think it makes it quite complex and quite challenging, in fact, to unpack. So, I mean, like Shannaz and Laura, I think I've thought about it from the point of view of power as well, and I have sort of my career worked primarily, but not exclusively, in these global institutions, right? And so what I've seen in these global institutions is, I guess I would break it down into three kind of big buckets of what immediately occurs to me when I think about, power in this space. First, I think about money, because I really do think that money is very key to this. Where does the money come from? What's it used for? What's it not used for? What strings are attached to that money? Who manages it? Who is accountable? There are so many questions, I think, about money that we need to actually unpack and understand. How the money flows is deeply important and linked very closely to who has the power and which institutions have the power. The second bucket for me is knowledge, and I think this has also been mentioned by Shannaz and Laura as well. Knowledge in terms of what counts as knowledge, what counts as truth. We're right now talking a lot about vaccines and drug therapies in the context of COVID, but let's remember that many of our successful vaccines and drugs have come really from indigenous people and local knowledge and know-how. And how has that been used and then for economic gain by pharmaceutical companies and us in the global health field. So I think knowledge is actually a hugely important, and Laura mentioned education. I think that's also really key in this. And knowledge is, of course, very closely connected to language. So what language do we use when we talk about, when we describe the problems that we're seeing, quote unquote? There's a sort of a lexicon in the development sector that is deeply problematic, lexicon around vocabulary. This is around beneficiaries and targets and compliance and capacity building. And, there's a whole string of phrases and words, I think, that are quite frankly very loaded. And I find myself now really questioning and thinking about, where did this word come from? Why do we use this? How did it get here? Why is it so common? So I think language is really an important thing. And then finally, when you think about power and I think about decolonization, I think about practice. And I guess that's because I sit in an organization that is, sort of a practitioner organization. So in global health, practice often means things like program strategy, design, execution, evaluation, sort of, the very stuff that we think that we're engaged in what we do. So, I think all of those steps in programmatic practice are open for interrogation and really should be deeply interrogated and perhaps, dare I say, revolutionized. And when I say revolutionized, I mean, turned on their heads. So, the revolutionary ideas that are actually very much also a part of global health. And so anyway, those are the things that at least come to me immediately. And I think the fundamental of all of those three are sort of relationships. How are relationships in this field created, maintained, built, strengthened, and used to further our collective aims.
Thanks, Anu. And I think that's a very helpful, the buckets that you mentioned, a very helpful kind of mental reminder of how, the coloniality of global health manifests. In particular, I was struck when you added language. And, I'm currently doing a scoping review on a particular research question. And I'm guilty because one of the requirements or the criteria that we included is that the articles will only be included if they're written in English. And so we need to start actually asking, how about other forms of knowledge, other articles written in Chinese or Spanish? A lot of those knowledge are being left out, because we've always thought that English is the lingua franca of global health. We need to start interrogating that. I want to go to Laura, and I know Laura wrote this very powerful op-ed asking, are we really for decolonizing global health, or are we just trying to show our wokeness? And I think, that goes boils down to, do we really understand decolonizing global health? Or are we just joining the bandwagon and, doing the hashtag and organizing our own conference so that we're able to tick the box, right? So what are your thoughts around this? Like building on what Anu mentioned, the four buckets and, the interrogation of power that is really at the heart of decolonizing. Laura.
Thank you, Renzo. And I would just like to, echoing with what Anu mentioned about language, because recently one thing that I've added to my definition of decolonizing global health, beyond just dismantling those, systemic oppression and the legacies of colonialism and racism in global health, part of it is also the repatriation of indigenous land, language, and culture. That is such a huge part. And that was actually one thing that for me that inspired that op-ed that I wrote, because I was even asking myself that question was, am I having these conversations because I want to prove that I'm using the right words, or that I'm also, using this in vogue term and I am in this movement, but am I really interested in that decolonizing? Because one thing that I've realized is that if we were to truly decolonize global health as we know it today would cease to exist. And the very discomfort that I had to sit in is that might mean that I'm working myself out of a job, right? If we're going to decolonize and we're going to address systemic oppression, it means that we're addressing health inequities, meaning that you don't need someone like me telling the narratives of Tanzanian people. I'm a Tanzanian American, but I still have a very different social political position in this world, meaning that I don't have to travel from America to Tanzania to do a research project. They can do their own research project. They set their own research agendas. Funding is not just flowing from Western, from these global health institutions that are where the headquarters are in Western, where it was the colonizers, right, who they were colonizers. And it's not a coincidence that is who now controls the money, and that is who now sets the agenda for what we do in post-colonial communities or in the global South. And so that is one thing that I really had to sit with. And I was like, and I was asking that question of my fellow working group members, where I said, are we really interested in doing this? Because it would honestly mean for a lot of us that the work that we do, which that is the goal, I want to work towards bridging health inequities, but that also means that as someone working with, HIV, treatment trials or behavioral interventions, I am no longer needed in the sense that I don't need to be the one telling the narrative. Indigenous people in post-colonial states, they can tell.
Laura,
sorry.
Yeah, your microphone got muted.
Oh, I'm sorry about that.
It's okay. You can just repeat that last line that you mentioned.
Oh, yes. So what I was saying was the key thing of, decolonizing global health is realizing that I may no longer be needed because I don't need to be the one telling the narratives of resilience. I don't need to be the one telling the narratives of what it's like to, my research is focused on HIV and mental health outcomes in adolescents. I don't need to be the one writing about that, and writing about that in English and publishing in a journal that is most likely going to be behind a paywall that even now, as someone who's recently graduated, I actually can't even access it unless I'm paying money. And so that is such a huge thing of thinking decolonizing would mean that that flow of information, that flow of knowledge it's reciprocal, it's back and forth. Western and English methods and language and, practices are not the standard. We have conversations beyond just in English. We can talk about decolonizing not just in these global North and Western spaces, but we're also going and asking, and I would really want to know, because one thing I always want to know, what would decolonizing look for my great aunt in Tanzania? What does she think of decolonizing? Versus me answering that question and really telling that narrative for her. What does it look like for her? And so that is one thing that I think of, with thinking of decolonizing global health, especially as a recent student and as somebody who had to sit in that discomfort of global health wouldn't probably, the way that we think of global health and practice and research global health would be very different. And that is uncomfortable because it means for many of us, we are no longer needed in the sense that the positions that we have been put in and the work that we do has been built on this systemic oppression and honestly perpetuates it. And so for really to decolonize, it means that we no longer do that work anymore. And what does that look like? And that is something that I've also been reflecting on recently.
Thank you, Laura. And you're raising a very provocative point here, because what you're saying is that ultimately we want, we want many of the organizations based in the Triangle, the schools of public health, for instance, in the US and Europe, to be doomed to obsolescence, because the countries, the old colonies have already built capacity. And when we say capacity building in its truest form, not in the global health style that we right now have, and that capacity will actually allow them to not just document, but to really analyze and solve the problems that they have, the local problems as they manifest. And so maybe later we'll get into the and Anu mentioned the fourth bucket, the practice. So what will need to change in the way we do quote unquote global health work, these global health projects. Is there a balance that can be struck, that we don't get obsolete, but at the same time, there's really respect, and maybe it's more of interdependence as opposed to a one-way kind of flow of dependence. I remember in a panel that I just attended last week, there was someone from one of my co-panelists said, oh, when it comes to mentorship, we hope that more people from the global north will be willing to mentor us from the global south. And I said, yes, I agree, but I think we should be more ambitious than that. We should have mentorship in all directions, because I think I can also be a mentor too to my friends in the US and in Europe, because we have wisdom and knowledge that perhaps can also help them address their problems, as we also learn from what the North, for instance, the lessons that they've learned. So in terms of the flow of knowledge, and Shannaz, you somehow touch on this. This idea of there are many systems of knowledge. Knowledge is not not singular but pluralistic. We already somehow mentioned in several parts of the conversation about indigenous communities. How can we amplify, these voices, these unheard, unseen voices, from the global South, again, as part of this, growing conversation around decolonizing global health? What do you see from where you sit, in South Africa, in the global South?
Thank you, Renzo. I mean, that's quite a big and difficult question, and I don't know that I have the answer, but I would like to say is that part of what keeps us going is that we love the sound of our own voice a lot of the time, and that sometimes it's about listening, listening, because, Arundhati Roy says there's no such thing as the preferably, wait, I'm getting her quote all wrong now, but there's no such thing as the silence. It's really the preferably unheard. People on the margins, they know who they are, they know what they want, they know what they need. In some ways, they're probably more innovative because they have less, and they're probably more innovative because they're somewhat chucked outside of the system, so they're innovating anyways. And in the African Decolonial Conference, Jessica Horn pointed us to really think about the question of praxis, and this question of, we're starting to think about decolonization, but decolonization is not necessarily a noun. It's not a metaphor. It's a process. It's a doing word. It's a process of doing. So what do we need to do, and how are we going to do, and who's going to inform this process of doing? Where do we look to? Who is going to teach us how to begin to do? Are we the ones to do it? Is it those on the margins, those who are disenfranchised? Is it those at the center? Is it those who sit in the spaces in between? And I don't know that we have the answer to the question of decolonization, But I think that as a field in health, as somebody who's been socialized into being a healthcare professional and then socialized into being a policy person, a systems thinker, I need to recognize that if I want to start the journey of decolonization, then I have to start opening myself up to thinking decolonial theory. And then I have to also think intersectionality as a theory. And to me, the starting point is that we need to ask, what does decoloniality offer us? In the same way that we've embraced what intersectionality offers us, you know. And one of the things that decoloniality offers us is this question that has come up right at the start of philosophy, that, you know, these 6 white men have informed us that the Cartesian philosophy is, I think, therefore I am. And a lot of this kind of philosophy that grounds who we are and how we think and what language, what systems, what context. Yeah, so I think what I was trying to really point us to is that, you know, that there is a whole body of theory and knowledge that we need to visit as as health scholars. We don't know this theory. We haven't really visited. There are many scholars that have brought a lot of knowledge, and I sit in South Africa where through inspired and informed by movements like the decolonizing movements of Rhodes Must Fall, that have really brought a lot of the Latin American scholars to our shores to teach us, to disrupt our knowledge, to de-link us, to give us an entry point into where and how we need to liberate ourselves in order to consider how this body of knowledge, decolonial theory, can then inform how we think about health systems. And one of the key things that I think it allows us to do is to see ourselves from a different lens. So then it starts to help us to see how we think about health from the lens of those who are marginal and those who are oppressed. And then we start seeing ourselves, how do we position ourselves? How do we continuously, in a reiterative process, consider our positionality in that journey, even when we sit in the global south, but yet we are products of westernized universities that are replicas of those universities in the north. So then when we situate ourselves in those boxes, we can see how these philosophies have informed our thinking today. And we can maybe then see that there are other philosophies, such as Ubuntu, that comes from the African continent, that doesn't see people as individuals, but sees people as we are because of the collective, that may inform a different way of thinking, firstly, about how we exist in the world, who we are as people, how we see health, how do we see well-being, you know? And it takes us and it shifts us outside of the mode of thinking about ourselves in relation to the market and the capitalist production, the commodification of health. The commodification of health so that I am healthy so that I can work every day from 9 to 5. And now in COVID times, when our precious time is creeped into, you know, there's no boundaries. We become workers. We are no longer human beings. We are human doings, you know. And then in that way, we constantly lose our connection even to Mother Earth and the nature that is supposed to restore us. You know, and there's an interesting story of how people from the Dutch East India Company, when they brought slaves to the South African colony of Cape Town, they also built these beautiful places like Kirstenbosch Gardens and Kew Gardens in the Cape. And these places were built as laboratories, just like our universities, just like our schools of public health, just like our anthropology departments. But they built these structures to come and test different plant species, whether they would exist and survive on the African soil. And so they brought these flowers from Australia, which are now draining the water, draining our soils. and have really damaged the ecosystem, alienating us more from our earth than ever before. So how can we not consider that there is something fundamentally wrong? There's something fundamentally wrong, and that we've normalized the way we live, the way we exist, the way we do things, you know. And for us to take seriously that there's something fundamentally wrong with who we are and how we exist today, we need to start asking who has other answers. But why have these indigenous land defenders in the US been targeted? There's a reason, because they have knowledge that we can learn from. Why are the San and Khoi people in South Africa, you know, why have their languages been destroyed? Why is their cultures been destroyed? Why even if we go back to London and the UK, back when the colonial project started with the witches of the UK, who were women who held indigenous knowledge of the land of England, why was there a genocide? Why was that one of the first moments of genocide? It's because the structures of power of the project of modernity recognize that they've got to other, they've got to alienate, they've got to create the system of alterity in order for the project to survive. So I think I'll round up what I'm saying by recognizing that Lance Lustiger, my co-convener of the African Health Futures Project, and myself, and all of the speakers at our convening, we came together recognizing that we need a conscientization project. And so African Health Futures is a conscientization project, one that takes seriously the need for us to liberate ourselves by drawing on different epistemologies, you know. As Sabelo Kancheni spoke about the epistemic crisis. So how do we consider other epistemic systems of knowledge? And we hope to do that through thinking, finding solutions, testing ideas, and starting to ask the question, what next? How do we take these ideas and move it to praxis and to practice? What Anu was talking about earlier. Thank you.
Thank you, Shannaz. Powerful words you've got there. And, you know, one, I really appreciate that you also touch on, you know, the environmental dimension of colonialism. My area is the intersection between climate change and health. That's the focus of my doctoral dissertation. And I think that's also the missing piece in the conversation, that, you know, ultimately colonialism of man over nature is something that we need to really stop. You know, otherwise climate change and all these ecological crises will not be abated. And again, these are just all the different, you know, facets of this colonial project that is still yet to be finished and dismantled. You also reminded us about the importance of really, you know, studying the colonial theory and intersectionality. And Laura, you know, when she was in Duke University, she was, you know, the Duke Decolonizing Global Health Working Group has been interrogating the way global health was taught, you know, being very historical and depoliticized. And maybe we need our global health curricula to have more the coloniality and political economy and the social sciences. And maybe Laura can speak to that as well, you know, the decolonizing of global health education and education at large that is needed. And then towards the end of your remarks, you already, you know, shifted, you know, from, you know, the theory to praxis. And I think our audience here is very interested to hear what can they do now? Decolonizing, as you've mentioned, is a process, and maybe it's a long process, but we need to start somewhere. And maybe I'll ask the three of you, what are some of the you know, the measures, your recommendations, for instance, to global health think tanks that are listening to us, the Department of Global Health in schools of public health that are also in the audience. What can they do? And of course, we don't want to just, you know, settle with the cosmetic and the low-hanging fruit. You know, what I'm noticing now is that every commentary, there's a tendency now to find someone from the global south to be a co-author. And we're not even sure if that's a genuine co-authorship or a token move. And so we also don't want that kind of unintended consequence, just, for the sake of quote unquote decolonizing, being politically correct, because the editors will reject your paper if they don't see an African sounding name in an article about Africa. So how can we go beyond the cosmetic, but also, be more practical? Because decolonizing may seem a bit abstract, but of course, definitely, important and challenging. Who would like to start? We don't need to follow the sequence that we just had for the past several minutes. Laura, why don't you start? Because
yeah,
about, maybe you can education, right? Preparing the next generation of global health practitioners.
Yes, you just touched on what I was going to highlight. And one thing that definitely a lot of educational institutions can do is looking at their curriculum and really thinking, what are some steps we can take in how we are teaching global health to the next generation? I think one of the reasons why we founded the working group was we were sitting as students after our second day of class and really thinking, we're being taught by these wonderful faculty, and they are so knowledgeable, but it just really thinking of there's something missing in that we need to be grounded in the fact that, one, recognizing the history of global health, the roots of global health, and then also by recognizing that history, by recognizing those roots, and moving forward from that. And so that's one thing that we've always advocated, as students and as a recent student myself, is how we teach global health to the next generation, and even how we teach global health to ourselves. What language we're using, what methods are being emphasized in the curriculum, what the outcomes that the outcomes that we say are the important outcomes that we need to focus on in our research projects. So I think that's one step, particularly from a student perspective. Education can be taught differently, is also, in addition to what language is being emphasized, emphasizing indigenous language and knowledge, emphasizing that in the curricula instead of just focusing on Western knowledge, and moving forward and saying it's gonna be both can coexist, but we're also gonna emphasize this and recognize that this is also a valid form of knowledge. This is also a valid research method. This is also a valid outcome that we can use and that we can learn and that we can practice.
Who's next? Any advice to the global health community who's listening to us right now? Shannaz, I see you unmuted.
Oh, sure, I can come in here. I mean, I think that, I ended off by saying that it's that we trying to recommend a solidarity project, one that is a conscientization project, that is a solidarity project that kind of brings us together, you know. And I think part of this is really recognizing that there is a lot that we can do. There is a lot that we can do in our spaces, and what we are doing, for example, I can only speak for myself, is in my work with community health workers. We are starting to situate their work from a labor perspective, looking at how they're exploited, as casual workers, as women, as Black women who do unpaid care work, whose bodies are racialized, whose bodies are also sites of violence, who sometimes have to walk into communities and see the worst of the worst in communities, and yet, as a researcher, what we're trying to do is center their voices in the conversation, even in policy spaces. We're trying to bring them into positions where they lead, where they are central to even the presentation of ideas. And my colleague Lance, who's been doing work on addressing access to sex workers, to healthcare services, has enabled the skills building within the research project, to enable the lead of the sex worker initiative to be somebody that leads the research project, that goes to international conferences, that presents the findings, that speaks to the body of knowledge. For us, it's about a reclamation project. It is about whose voice is in front. It is about whose face is represented. It is about which language and how. Who is the authority over my experiences? Nobody, you know. So how do we start to undo and shift? So these are some ways, and I suppose this is an ongoing conversation, and I look forward to hearing and learning from Anu and Laura.
So now, how about Anu? My question is, what can organizations in the Triangle, like IPAS and others, do as a contribution to these big project of decolonizing global health, which Shannaz mentioned? It's continuous. It will never end in this webinar.
Yeah, so IPAS itself has embarked on a very on an organizational transformation process that will take a couple of years to kind of come to fruition, and it is sort of very much an experiment for us, and I think it is reflective of these conversations and my own thinking and reflection on my role in global health and where I as a person, but IPAS as an institution wants to go. And I think this is, so, you know, that's a very long conversation, so I won't go there, but I think there is really a value around building and creating the kind of institution that you can. I want to be clear that this conversation about colonization and decolonization is really challenging because these concepts are embedded in our structures. This is not something that we as a little tiny institution of IPAS, which is a very modest organization, can undo all by ourselves. Nonetheless, I am the CEO and I do have some authority right now, and I do have leadership responsibilities, not just for my own staff, but for the work that we do. So I think that we can affect change in our own sphere, and that's what I'm attempting to do with IPAS. You know, you mentioned, Renzo, the value of interdependence. That's actually a core value for IPAS and has been for the last several years. And so we are digging deeper into what does that actually mean, interdependence? Is it solidarity? Is it allyship? Is it, you know, leadership? If so, what kind of leadership? And so I guess I would say that what I would recommend is really to my colleagues in the Triangle and beyond is to further the analysis of decolonization, further it so that you actually examine all of our practices, everything from operational issues to programmatic issues. I think it's embedded throughout, and I think we actually have to do a really objective job, which is very hard for us. Of untangling. It's hard because we're part of it. We're all complicit. It's very, very challenging to find an objective view. But then I would approach it not from a deficit point of view. You know, I think Laura referenced we work ourselves out of a job. Yes, very likely we do. But what do we gain from this process? What do we reclaim? The word that Shannaz used, which I thought was really powerful. You know, I mean, Shannaz mentioned indigenous knowledge and reclaiming that knowledge, but I also think that there's there's a way of thinking that has been privileged and rewarded in our current way of working, which is limiting. I am constantly struck by how we think about in dichotomies, always in dichotomies, and never in continuums, never in, you know, kind of spectrums. And that dichotomous thinking, sort of back to Descartes, is, you know, part of the challenge in the field. So I think we need to think about this from a what do I gain point of view by doing this, you know, and what assets do I bring? What can I learn? What can I build? That I think is very powerful. And then finally, I think we have to each of ourselves be really aware of our personal awakening and personal changes that we need to make in ourselves and around us, and that can be quite challenging as well.
Thank you so much, Anu. Wow, I think, we just gave a huge homework to all the attendees of this panel. As Shannaz mentioned, it's not going to end today, tomorrow. It's a continuous journey that we will need to embark together. But also Anu and Laura have made a call to acknowledging our privilege, looking at what we collectively can gain from ultimately from these decolonizing journey, and how we can really be agents of transformation. But it will need to start where we are. It begins at home, in our own organizations, and ultimately in ourselves. And so thank you, Anu, thank you, Laura and Shannaz, for your words of wisdom, and hopefully this moves us one step further in this again long journey towards decolonizing global health. And again, thank you to our participants for tuning in. Let's all stay safe and enjoy the rest of the conference.